Thank you very much, and thanks to all of you for being here tonight. I really do appreciate it, and thanks to Dr. Boswick, and thank you, Eric. I'm a pediatrician, but I'm also in hospice and palliative medicine, and so I will speak a little to the compassionate use at some point if it comes up, and I'm happy to talk to anybody about this further if you would like. Officially, I think very much so my position is that this is neutral. That is my position at this point. And I definitely do not condone the use of illegal substances. And more so as a pediatrician, I do not condone the use of inhaled hydrocarbons. I think though, however, at Gillette Children's Specialty Healthcare where I do work, we do have several areas that this bill does affect, including epilepsy, spasticity, dystonia, and palliative care. I feel like as a clinician, as a physician, we should actively participate in these discussions. We should participate in the research around this as well that can help us to improve the care of our patients. This discourse is very crucial, and it's often productive as well. I do feel the commitment to improve the lives of our patients and their families. And we will continue, and I will continue to be involved in these discussions around medical marijuana, especially with the possibilities of how it may help the treatments of the conditions such as epilepsy, severe dystonia, spasticity, and its a role in palliative and hospice medicine. And it really does come down to research. I mean, we have had a lot of issues going out there. I think when you look at whole plant marijuana, it would be hard to say in this joint, what is the dose concentration? What am I actually delivering to my patient? How could I quantify that? In this brownie and whatever, what is the dose of concentration? At the same time, if you have access to such compounds as Sativex in the UK with THC and cannabidiol blends, you can actually then talk about a dose and concentration. We can study that. We can see how it interacts at the CB1, CB2. What are the effects? We can design studies to work with this. And when I look at some of the other medications available to treat some of these issues, and we're down to our 5th, 6th, 7th choice, and my patient's still suffering, I am going to look for other means to provide care to my patients. Thank you.
Thank you.
Dr. Specker.
Yes, I have the last one.
You have the
Oh,
last
I don't
word.
think it's on. Is this on?
Yeah, just pull it closer to you though.
Thank you. Okay, so I have a number of different perspectives, or different hats, I should say. I'm at the University of Minnesota, so I'm involved in research. I am an addiction psychiatrist, so I've been active in treating patients for many years. And I've been involved with some of our societies, medical societies, former president of Minnesota, Society for Addiction Medicine, which is part of the American Society for Addiction Medicine, a member of the Minnesota Psychiatric Society, who've also taken positions on this. So I did want to share a bit about that. My first hat, though, was in dealing with addiction. And while I don't want to belabor the point either, I do want to make a few comments about youth in particular, because that's what we're commenting on as being a high-risk group. There's a variety of studies. One is looking at the rates of use of cannabis in states where there's medical marijuana and states where there's not. And what is clear is that those states that do have medical marijuana legalized, the rates of marijuana use in youth are elevated. They're clearly increased. Why is that important? Well, obviously the more use there is, the more there is the risk of addiction. And that's one of my perspectives, is that it does increase, without question, of risk for addiction in youth. Also, we need to look at what message we're giving youth to. Because when you look also at the studies, when you have the perceived risk of a substance being lower, and when you have the increased availability of a substance, those are two components which will make it much more likely for persons to use, and specifically adolescents. So I think we have to keep that, like Charlie said, kind of in the forefront of thinking about what are we putting, who are we putting at risk versus who are we helping. All right, so that was one aspect. Another aspect that I wanted to comment on was who actually is getting medical marijuana in states where it is approved. And we all have compassion toward individuals that are end of life, aid severe debilitating pain, but who's actually getting it from the dispensaries? About 1% of individuals that have those conditions are the ones that are getting marijuana at the dispensaries. It is the younger age population in their 30s, those with back pain, anxiety conditions, et cetera, are the ones that are the ones at the dispensaries that are receiving the quote medical marijuana. So I think perhaps what the bill is intended to do is really not what happens. Okay, so that's one point. And then I wanted to share the recommendations from the American Society of Addiction Medicine, as MMA is looking at. Well, let's look at what other societies, how other societies are doing it. And I think ASAM has been very clear in terms of policy. And I just want to share a bit of that. So one of ASAM's recommendations is that the same standards should apply as exist for other prescription medications and devices. In other words, it should go through the official channels of the FDA, where you have studies supporting efficacy, where you look at risk mitigation strategies, etc. There isn't, if it was approved, there isn't any dose ability to regulate doses the same way we do with other medicines. So it's really not being approved as a medicine. Medicines have, this is your dose, these are the risks with it. This is a healthy delivery system. Clearly smoking is not a healthy delivery system, and I as a physician have a very hard time recommending, or what's the word, signing off, certifying for a particular method that is harmful, that is going to be harmful. Okay, so other recommendations, okay, FDA approval required. Reject smoking as a form of drug delivery because it's not safe. Rejecting local ballot initiatives. So this is either a popular vote in some states or it's a legislative vote, but it is not a medical vote. Physicians are not making this decision. It's non-medical persons who are making a medical decision. Minnesota Psychiatrist Society is also taking a stance which is against the legalization of medical marijuana. So we have our Minnesota societies that are taking positions on this. I think we've talked about the being a psychiatrist being the risk for developing psychosis and schizophrenia, and that the literature, I think, is very clear on that, so I'm not sure to belabor that point. So I'll stop.
Thank you very much. You've kind of heard a brief introduction of the panelists, and I'd like to now have another 10 to 15 minutes of questions for the panelists. And go ahead and you can kind of speak up. Our mic is not working, so please speak loudly, and if we have to, we can readdress. And go ahead.
This is not to any one particular individual. I appreciate all your thoughts. I agree that we really should have evidence-based and more studies and all of that. But I will say we should be very careful about that, because my training in medical school and residency on opioids, addiction, chronic illness was pathetic. It was almost zero. For many years, probably not even yet, am I really educated enough on opioids. And I know I'm not alone. So we have such a long way to go with catching up to the drugs already out there. And so I just think that we need to be really careful when we say, well, we can't have marijuana because we don't know enough about it, but we let everything else out of the bar before we even know what we were doing with it. And those of us in primary care who are trying to deal with chronic pain, you have tremendous lack of really good resources. And so I just want to throw that out there. We really have a long way to go with really getting us all up to speed on just the substances we have, let alone marijuana, which I would support, by the way. But I guess I want to say it's like we really need to get our act together in terms of managing chronic illness, managing opioids. And maybe it's gotten better with medical school and residency, but boy, we have a long way to go if it was anything like what I got. So that's my comment.
So your comment did not have a question in it when I and that's fine. But you said at one point you support the medical legalization, the legalization of marijuana as a medicine. Did I hear you say that, or did you say?
I did say that, this is correct.
Okay, thank you. And, this is a venue also, we want to hear what your thoughts are. It's not just asking questions, so your personal thoughts are helpful to us as well. Is there another question or statement?
I realize that wasn't a question per se, but it certainly was a relevant comment. And I'm sure I have thoughts and opinions about it.
That's fine.
Yeah.
Yep.
Brief reaction. Two reactions. One is that I have tried working with the FDA on the question of opioids, and to say that the FDA is some kind of like a trustworthy organization up on a pedestal is absurd, right? I mean, it's absurd what they've done with opioids and Zohydro, et cetera. That's beside the point. The pro-marijuana advocates are so full of false choices, right? It's all marijuana is better than tobacco. Marijuana is safer than alcohol. Marijuana is safer than opioids. Those are often, first of all, false choices because it is not marijuana or tobacco. It's usually both. It is not marijuana or alcohol. It's usually both. Those are false choices, and yet have I heard someone compare marijuana favorably to broccoli or to a half an hour on the elliptical 4 times a day, right? And so when those favorable comparisons come up, then I'll listen, but when you're comparing marijuana to opioids, which is a disaster, that doesn't mean much to me. It's a disaster right now.
Okay, any other statements from the panel? I'm sorry.
I'd like to address this. It's not a choice. I mean, it's not. We're not being consistent by prohibiting marijuana. We already have drugs that are less safe and possibly less useful in some respects, and we're allowing them. And we're not allowing this one, which may be useful. We need more research for sure, but I don't see a reason to not allow that person with cancer use a drug that actually works for them.
So you would, what I'm reading between the lines is you would say you'd support more change in class to a class 2, which will allow you to use it, than necessarily making it free to everybody in the way the law states.
It should be allowed for use in patients who actually need it. I'm not a politician, I don't understand politics. But the point is, if a person comes in and they're telling me they're smoking because nothing else helps, and this helps, and it's illegal, it's not fair to them to put them in a position where they have to break the law to actually get relief from their condition.
Any other panel comment before I go to another question? Seeing none, I called on him earlier, so.
We talked about the lack of data, but is there any systematic data that is coming out of Europe, the UK, Canada, places which have had a more legal approach to this, or they haven't been hampered by a Schedule 1?
Yeah, there's studies in Australia, there's all kinds of studies that show they have brain scans, what happens to people's brains after age 16 to 20, as he was saying earlier. Yes, it affects your brain, it can permanently change neural pathways. We have PET scans, all kinds of scans showing real hardcore evidence. There are places that are doing it. In Denmark, they're obviously doing it. And you can read these, they're published, lots of articles. There's way more on this than you think. And I think most of it I've seen, like you were saying, Charlie, most of the stuff that the pro people say is just, again, stuff that's good sound bites. But if you actually look at the evidence, not many people actually can show you, demonstrate evidence, except for the stuff that's damaging. There's lots of that, more than you think.
I also want to make one comment about it. It isn't true that there isn't research on cannabis. There certainly is. There certainly is a great abundance of research. What you're talking about in terms of Schedule 1 and so forth is actually getting the substance to do something like a laboratory trial, et cetera. But it isn't that we don't have research on marijuana.
Bob, and then we'll go back there. We'll kind of work our way around. Thank you.
So Eric, I appreciate knowing more about the bill because it seems to me that they've tried to build in some of the protections around limiting where you get it, limiting who can do it. From a Minnesota medical perspective, I would say that maybe limiting it to doctors instead of all LIPs. But and I don't see, and this is my question to you guys, this doesn't seem to me to be the pathway that teens and adolescents and 20-year-olds are going to go to get marijuana. And so, I mean, they're not going to go get the doctors, and maybe they're going to steal it from their parents, you know, little canister, whatever, however that's distributed. But that doesn't seem to me that that's going to be the pathway, because it's so available right now, and probably maybe even in stronger form than you would get through medical marijuana. And I would appreciate your comment about, especially about the increased use.
So for well-known public health, that initiation of any behavior, initiation of a drug is governed by basically 3 variables, which is availability, social acceptability, and perceived risk. And these 3 parameters have been tracked for 30 years by a group called Monitoring the Future. And you can Google monitoringthefuture.org, and they have this data for 30 years out, 40 years, since 1980, whatever it is. And so availability, interestingly, has been 85 to 90% of high school seniors know where to get marijuana forever. So availability is not the variable we're worried about here. High school seniors have always known how to get marijuana, 85 to 90%. The variables are perceived risk and perceived social acceptability. And those have wide vacillations over time. So Nancy Reagan just said no. Actually, perceived risk went up and use went down. As much as we may hate to admit it, that sort of worked for whatever reason. But this does not affect availability. This does affect perceived risk and perceived social acceptability. That's sort of my response.
Right, but it also may affect potency too. I mean, that's another factor, is how potent the substance is.
Okay. I'm going to try and work my way around.
One more thing.
Sorry.
The studies I have seen do not indicate that the use goes up with legalization of medical marijuana. There's many states that have done these sort of studies, and this doesn't seem to change the use.
Dr. Reisenkopf, I got a health economics question. I'm sure there's just plenty of money for the treatment of chemical health problems right now. So adding another substance is not going to be a problem. Is that true?
Well, one might say that we're diverting all the corrections, money we're spending on incarcerations, we could re-divert that. You know, the economics is so fuzzy with this. So there are a lot of arguments in a lot of directions. For example, we're going to save a lot of money on corrections facilities, incarcerations, and we're going to have fewer nonviolent offenders in prison. This is more of a legalization argument. But obviously there's a huge infrastructure also to build around testing in potentially intoxicated drivers. That infrastructure is not free, so someone's got to pay for that infrastructure. So there's lots of stuff.
Yes.
So from a public health point of view, you mentioned some of the things that I think we have a responsibility to address when we talk about medical marijuana. One of them is the addiction and the potential of the harm from that. But I think we also need to address the harm that's being done right now by the illegalization and what's going to happen or what is happening to a lot of our patients and a lot of the people in the community. And not just when they use it for medical reasons, but when they use it for recreational reasons. But as doctors and as speakers for public health, we should address kind of a huge crisis.